Explain how you evaluate and manage increased LFTs in patients with colorectal cancer who are receiving an immune checkpoint inhibitor. When evaluating increased LFTs in patients with colorectal cancer on immunotherapy, it's important to work up the patient for every potential cause for hepatic dysfunction. A lot of these colorectal cancer patients have liver metastases and therefore can have baseline hepatic dysfunction that was there prior to starting the immune therapy. So that being said, make sure you do know your patient's baseline LFTs. If you do see a spike in LFTs, work them up to see if they have disease progression. Consider ordering imaging or an ultrasound or an MRI, depending on how you're following their disease. Another thing that you'll want to consider is hepatotoxicity from other medications. If these patients have liver metastases and baseline hepatic dysfunction, they're not going to metabolize other medications or other herbs that have become very popular in our patients either. And they're at potential risk for even worsening hepatotoxicity from medication, particularly your statins or acetaminophen, which are commonly used in a large number of patients. Another item to consider when you're evaluating a patient for a potential immune event, another item to rule out would be viral issues. Look to see if you've checked the patient to see if they have hepatitis, if they have Epstein-Barr, CMV. These are other issues that could potentially cause hepatic dysfunction in this population. If you've ruled out biliary obstruction as well, that would go along the lines of disease progression, but you also want to rule that out. And if you'd rule out that, as well as these other aforementioned items, and you determine that it is an immune event, what you'll want to do is start the patient on high-dose steroids. The recommended dose is 1 to 2 milligrams per kilogram of prednisone or the equivalent per day. You'll start them on that dose and then follow their LFTs routinely, religiously. Some people check them every few days, some people once a week. It really depends on how high the LFTs have spiked. But you'll want to follow the LFTs while they're on steroids to make sure that they are going in the right direction and responding to steroids. Once the patient's LFTs have improved to grade 1, which is a mild elevation, or to baseline, you can start a very slow steroid taper. Of course, the immunotherapy is going to be held during this entire time. Once the LFTs have spiked, you'll hold the immune therapy just as you're starting them on steroids. But again, when the LFTs are grade 1 or back to baseline, you start this steroid taper. You'll taper them over a 1-month period. And depending upon how elevated they were, you can consider possibly restarting the patient on immunotherapy, but there may be grounds for discontinuation as well. Now, if the patient is not responding to steroids, you start them on steroids, you're following their LFTs, and LFTs are going in the wrong direction. At that point, you are going to need to consider using other drugs, notably Cellcept, which is a type of anti-rejection drug. But that's very rare that happens. Usually the good news is that most of these patients do respond quite well to steroids when they've developed an immune-mediated toxicity of hepatotoxicity.